moved to doing a fair amount of direct contracting with providers, and we feel like that's a good opportunity to have a seat at the table and influence the provider community directly. And the more innovative areas and big areas that we've been working recently is our accountable care organization direct contracts that we've been doing. The basic premise of these ACOs is we provide a strong incentive for our employees to get their care at these accountable care organizations. That pushes revenue and volume to these integrated health systems. And in return for that, they guarantee us quality, they guarantee us financial outcomes, and improve the member experience. I'd say we're very pleased with these with our accountable care organizations so far. The quality has been definitely improved versus our unmanaged population. Pretty good demonstration of that.
On payment reform, I think that the Medicare program should stay focused on ACOs. I think the evidence has been small, but it is relatively significant. If you embrace two-sided risk, there should be a lot less regulatory requirement when the ACO does that. We should be promoting all-payer ACO collaboratives like the Vermont initiatives, which brings together the commercial, Medicare, and Medicaid, and has all of the hopefully we'll get all of the signals aligned. And I think drugs should be added to the ACO target.
And so it's been interesting for me, having lived in this space for a while, that we've kind of focused on this shift from fee-for-service to capitation, and really we know that in fee-for-service we incentivize overutilization. And in the primary care world, as we've shifted to capitation, we've addressed some of those perverse incentives, but we still continue to pay specialists through fee-for-service predominantly, and whether that's through a bundle payment or just a traditional fee-for-service mechanism. And when we bundle at the procedure level, we get exactly what the system motivates us to do, which is we get more procedures whether or not those procedures are appropriate or not. What we've learned from this is we need to move upstream from bundling at the procedure level to bundling at the condition level, which is what we're now doing in Austin. We have a bundle payment for the management of hip and knee arthritis. So what does that do? Just as the bundle payment at the procedure level incentivizes us to change our behavior and coordinate care between acute and post-acute providers, now we have been forced to coordinate care across the spectrum of people who manage arthritis. So what have we learned from this experience? We've learned again that the payment model, changes in the payment model drive changes in the delivery system, that bundle payments incentivize greater coordination and communication across providers, but bundling at the procedure level limits value creation by ignoring the concept of appropriateness, that bundling at the condition level drives value by incentivizing greater coordination and communication across all of the providers that manage people with chronic pain.
But what we're really driving for is healthcare transformation, and we want to see the delivery systems change the way they deliver care.